So, for the attendees that are here, you should have received a brief survey in your email. It's legitimately less than 2 minutes, possibly less than 1 minute. So, if you have a chance, open it up, quickly fill it out while I'm giving a background. But brief background to why we do this. I went from psychiatry to HPM fellowship over a decade ago. I adore my career, but it was quite the journey to figure out the path, find mentorship, integrate the skills, think through what careers could look like. And so now that there's a much more solid community of psychiatrists doing work at the interface of palliative medicine, we really want it to be a resource for trainees in the journey so that you guys could all have mentorship and insight and support in the process. So we do 3 group mentorship sessions a year. They are not recorded, come with any questions, and it's more of a free form conversation. And then we do 1 panel a year. So 2023, we had 4 psychiatrists who had done HPM fellowships and were practicing in different roles. 2024, we call it the new kids on the block. So people who had just gone through that training path to give us some updated scoop on what it was like. 2025, we did 2 psychiatrists and 2 HPM psychiatrists, 2 CL psychiatrists who work at the interface of palliative medicine, and they sort of compared and contrasted what those training paths are like, what the jobs look like from one to the next. And all of those are available and online. And today we have a different take. There's 3 people here who are not psychiatrists, but they are honorarily loved in our hearts for being HPM fellowship directors, all of whom have trained psychiatrists in their program. And we are super grateful to the 3 of you for coming, for sharing your time in these non-work hours, to give us some insights that I think you'll be able to reflect on in ways that the rest of us haven't been able to. So everybody who's attending, please throw your questions into the Q&A or into the chat, and I'll be sure to ask them. But I will start with some questions that we get a lot in these sessions and let you field them. So just to orient to everybody who's here, we've got Carly Zapata, who is our HPM Fellowship Director at UCSF. We have Josh Hauser, HPM Fellowship Director at Northwestern. And we have Molly Biewald, HPM Fellowship Director at Mount Sinai. So whichever one of you wants to be the brave one to go first, the first question I'm going to throw at you is, do you feel authentically that you are equally open to training psychiatrists as much as you would be to any other field? And if so, what excites you about the idea? Are there any, particular strengths or perspectives you think psych trainees bring to the field?
Happy to go first. I would say I'm even a little bit biased toward psychiatrists and other people that are not IM or FM trained. I think in my time as fellowship program director, I've seen it brings so much to the fellowship class to have a diversity of training pathways. So I think it brings so much to co-fellows and to other attendings and other team members. So I think we really welcome people applying from all training pathways, especially psychiatry. And I think psychiatrists bring so much expertise in so much of what we do in palliative medicine, and I am trained myself in such a different perspective. So I would totally welcome psychiatrists. Others?
Yeah, Molly, I was going to say a similar thing. So I'm also an internist by original vintage, even primary care, the original path that I had in my residency. But as with maybe some people in the world, I struggled between psychiatry and medicine myself in terms of my own primary path. And we at Northwestern and the VA, which I split my time between the 2 places, are really heavily internal medicine in terms of our faculty. And it's interesting because we get calls from psychiatry residents, from OBGYN residents, from neuro residents, from emergency medicine residents, saying, "Oh my God, you guys are all internists. Are you sure I can apply?" And I'm like, "Oh, please, please, please." So we're trying to remedy our own lack of disciplinary diversity. Now we're getting there, but I just think the skills, the outlooks, the experiences of the psychiatrists whom we've trained, and it's not been a huge number, it's been a few over the years, have just been so valuable. And in at least two of the cases, those relationships have continued well beyond fellowship. So I was thinking, because Danny, you very kindly gave us some questions in advance, so I appreciate it. I was thinking of the psychiatrists we've trained, and I'm happy to talk about this more as we go on, but 2 out of 3 of them, we still work together, and that's a gift.
I would agree with all of those sentiments, and I'm not sure that I have all that much to add, except to really emphasize that I think to Molly's point, and Josh's as well, what we really value is variety of training background, and certainly psychiatry is among the specialties for which we have the most enthusiasm for people who are not internal medicine and family medicine trained. I also am internal medicine and primary care, was a primary care resident, and the richness of those different backgrounds within a fellowship cohort, and then the ways that we as faculty and our professional teams get to learn from all of those diverse backgrounds really adds so much to our division and to the specialty in general. And I think to Josh's point, we want psychiatrists both as fellows for those reasons and because we like hanging on to them for faculty appointments thereafter. I would absolutely be a less I would have fewer palliative care skills in my own wheelhouse if it were not for having Danny on faculty here. And I think other people would say that as well. And so we want diversity both in the fellowship class and our faculty. And we are unlikely to achieve that in our faculty if we don't have it in our fellows.
Thanks for saying
so
that.
Yes,
Carly.
please join us.
I will also reflect, it's heartwarming for me to hear your answers because the field has evolved a lot. When over a decade ago I was applying, half of the programs blanket, like would not interview you if you were a psychiatrist. And then the other ones, Eric Widder, people had to write letters explaining why they should consider interviewing a psychiatrist. And the first question was, can you hack this as a psychiatrist? So I think your responses are heartwarming and also a really beautiful sign of this way that this field that is interdisciplinary in its heart has truly evolved to increasingly become interdisciplinary in actuality. So my next question, what challenges or growth edges have you seen psychiatry trained fellows encounter during fellowship? Clinically, educationally, professionally?
I'm happy to start. So I do think it's not random that there are a lot of internists in palliative care and a lot of family medicine folks, because it's pretty medicine-y, at least from my perspective, and it's probably pretty pediatric-y on the sort of child end, and it is. So I do remember, in fact, one of the psychiatrists whom we trained, and I hope it's okay to use names because I'm using them in really nice ways. Teresa Vente, who's now at Stanford, she's a child psychiatrist, and also did pediatrics. But I remember when she did one of her first weeks with me in July of year X, where X is 7 or 8 years ago. She was like, "Oh my God, there's so much medicine," and I said, "Yeah, there is. You're right, and there's a lot of psychiatry that I'm missing." So I do think that can be a challenge, and I think we've had conversations over the years as fellowship directors, not just for psychiatrists, by the way, for emergency medicine, for neurology, for PM&R, for all sorts of non-medicine fields, about whether you need some kind of internal medicine boot camp. I have no idea what that would look like, honestly. So none of that's come to pass, at least at Northwestern, but I don't think other places. So sometimes sort of the volume of medicine, sometimes the volume of inpatient stuff. So not just medicine, but inpatient medicine, ICU stuff, which, I think can be challenging for any. It can be challenging for me. It is challenging for me, but especially when you've not been in internal medicine for a few years. I think that's a very surmountable challenge, but that is a potential challenge that we've seen.
I think we've had a pretty similar challenge. I think our psychiatry trainees have brought in so many skills that more than make up for it, like expertise in dealing with complex personalities and anxiety and delirium are like bread and butter consults for us. But I think sometimes, like Josh was saying, in ICU settings and like vent management and things like that can be just sort of unfamiliar. But I haven't seen anybody not be able to like ask good questions and get coached in what they need to know. And I think, like Josh was saying, it's sort of the same challenges that any other trainees coming from backgrounds where they're not familiar with that, like our surgeons and our EM trained people. So I think it's very surmountable. And I think you just need to go into it with an attitude of like, I'm here to learn and ask for help when I need it.
Mm-hmm.
Yeah, I agree. It makes the learning curve for some things a little bit steeper, and we are a training program, and it's very much our job to kind of help you stay on that curve as long as you are interested and open to learning those things that were not, part of your choice for psychiatry training initially necessarily. There is a lot of medicine, and that comes up for medication management in the ICU. And I think a more subtle way where that shows up sometimes is around prognostication and complex communication that includes prognostication in the expected trajectory of lots of serious illnesses. And so sometimes our psychiatry trainees have spent a little bit more time reading about those, or we talk much more in depth about them in clinic, for example, but again, not insurmountable. And I would say the kind of trade-off of having the hospital be a less familiar place is that the psychiatry fellows that we've had are really adept at clinic management, which is kind of the opposite for the surgeons and some other specialties. And so there are some ways in which the learning curve is steeper, and there are some ways in which you are really well prepared for some aspects of fellowship.
Maintaining a clinical frame is our jam. And this is how not to facilitate, because I'm just going to keep throwing my thoughts in, but I will add that I think everything comes with its pro and its con, because the flip side of having a little less of the nuanced internal medicine background is sometimes I will have a colleague who's very into like the vent settings or something, and by nature of my training, I'm like, can only see the big picture. I'm like, oh, this doesn't look good. This kind of looks good. And so my ability to translate the big picture for patients is actually sometimes aided by those not being as familiar with the minutia, but everything comes with its pros and its cons.
I mean, sorry to interrupt, Annie, you're about to say something, but I mean, one thing that's interesting is that just about every patient, at least at Northwestern, the VA already has an internist or a hospitalist, et cetera. I mean, they have an internal medicine doctor almost by definition. I mean, they might be on a surgical service, or they might be in ER, in which case they have an emergency medicine doctor and they have a surgeon. So part of this is sort of how we, parse things out and what we all attend to. So I don't think it's a panacea to be an internist in palliative care. Far from it.
Yeah. And Josh, you got at this like, okay, it doesn't seem, it's not an insurmountable problem, but would you say that if a psychiatrist came in feeling a little unstable or a little insecure about this specific challenge, do you see most of them really get their footing by the end of the year, or does that?
They've done just great. And, does it mean that I might talk with them a little bit more about sort of basic medicine stuff, just like they may talk to me a little bit more about basic psychiatry stuff, however defined for either of those terms? That's normal, right? And so I have not found this at all uncomfortable or awkward. And I think the key is for any of us, whether on the internal medicine side, whether on the psychiatry side, whether on any side we're on, is just to be very sort of transparent about things we have questions about, things we're curious about, things we'd love a little more advice about. I mean, we're all kind of adults in this world, and as fellows and as attendings, and so we just kind of roll that way.
That's remained true in attendinghood for me, for sure. So. Okay, I get this one at every mentorship session we have. It will be residents who are at a program where psychiatry and palliative care have very little interaction. They are very interested in this career path, but they don't have easy access to HPM rotations, HPM didactics, HPM mentorship. So they worry about how they can stand out as fellowship applicants without having any of that in place. And so what advice might you give?
I would say to be transparent about those limited opportunities, if that exists, either because you are at an institution that has plenty of palliative medicine, but there's not a lot of interaction with the psychiatry department, or you might be at a place where there isn't a big presence of palliative medicine, or as sometimes even happens here, there are not enough kind of rotator spots for you to do that elective before you apply. So there are all kinds of reasons that people don't necessarily have as much palliative care clinic experience as they might want, and or access to someone from our specialty who's going to write a letter of recommendation. And I would say what I don't want to speak for Molly or Josh, but I would say often what we're looking for is that you have made the most of the opportunities that you have had, as a demonstration of interest, as just an explanation for why that might look different compared to some other applicants. And so I think my recommendation would be to lay that out in your application, that you got as much clinical experience as you could given the setup of your institution. And sometimes that can be kind of supplemented with other experiences with interprofessional teams, which is often what we are hoping people get on their palliative care elective, and that is really necessary before fellowship. And so just kind of an explanation of the opportunities that you have had or haven't gotten to have and why, and then some demonstration of how you've gotten some of the core skills, even in the absence of that rotation or longitudinal clinic experience or whatever it is that might exist or not where you are.
Totally echo that. And I would say also, I get emails every week from psychiatry people in our system. Like, we don't have an established pathway with them, but if you email me, I will help you find a way to get clinical service. And I'm sure it's the same at many institutions. So find the fellowship program director and ask them your question, because they'll be excited to hear that you want to apply. I would say when I'm reviewing applications, I do really want to see that you have some clinical exposure to palliative medicine. I think that is really important to see what the day-to-day is like and know what you're getting into before you sign up for this. And I think I've seen people in a lot of training pathways who don't necessarily have access to elective time, as Danny was saying, like on time before you apply. And I think even seeking somebody out who will let you just like round with them for half a day, spend a couple days in clinic, like it doesn't have to be a big formal thing. It could be that you spend a weekend with the palliative care team, like however you can seek out some exposure to like what is the clinical work that we're actually doing. I think that is really important.
I mean, the other thing that I was thinking about is, I agree with Molly and Carly, but the topic of like cool ideas applied to palliative care. So another one of our former fellows and present colleague and friend is a colleague named Indrani, and Indrani did a talk. I honestly think it was when she was a fellow, but I'm not totally sure, so that's on me. But about like attachment theory in palliative care. I'm like, what? Attachment? Like what? And of course, that's like totally fascinating and amazing. And so that's an example, because attachment theory, from what I'm told from friends like Danny and other people, and is like a big thing in psychiatry and a big thing for humans. And so, like, what is the implications of that for palliative care? Now, you don't have to have any exposure to palliative care to kind of think about that and sort of review an article and talk about that and write a personal statement about that. And again, I'm not kind of micromanaging anyone's desires, but just thinking about unusual ideas in a field. We'll call it psychiatry. We could call it PM&R. We could call it neurology, and how those might reflect on, augment palliative care is something that I look for and think about with applicants from any field, including medicine, by the way. But in the case of psychiatry, what we're talking about now.
I adore Indrani, and it also tickles me to hear you say like call attachment theory an unusual idea in a field, because it is unusual in somewhere like hospice and palliative medicine, but it's also wild. That's unusual, because
like, why is that unusual, right?
like why is that? Let's make it usual.
Right. No, exactly. Yeah, no, that's my point exactly, Danny. Totally agree.
Yeah. So I hear some like creative ideas coming in. I guess the follow-up question, and Molly, you kind of mentioned this, is do you feel like there's some level of due diligence then that someone has to find some way to show you that they know what they're getting into here?
I think over time, I have grown to feel very strongly that people need to have some clinical exposure to palliative medicine. I think people come in with a lot of misconceptions about what the day-to-day life is like. And I think it's really, really important, if you're choosing this training pathway, to have some real exposure to that.
Partly, well, not partly, like mostly for the applicants, not for us. Like it's not in anyone's best interest to start fellowship and think, oh, this is not what I thought it was going to be.
And to be very concrete, I think we get a lot of applicants coming in who like think that the day-to-day life is going to be like that one really wonderful family meeting you had where everybody got along and it ended with like everyone crying and holding hands and it was so beautiful. And like that does happen, but a lot of what we do is really contentious and a lot of like there's a lot of other stuff outside of that. And I think it's really important to go in with your eyes open about what you're getting into.
I'm seeing one question in the chat. Thank you, Brendan, for asking a question. Brendan says, I recognize that a lot of palliative care doctors wear different hats, working as a neuro floor attending for a few weeks a month and then an HPM attending for the other weeks, for example. And I was wondering about how realistic hybridized jobs may be between psychiatry and palliative care, i.e. cross-appointed doctor who serves on the palliative care consult service for 2 weeks and then has a role with the psych department for other weeks, or do most people tend to go wholesale into HPM and not wear distinct hats in psychiatry?
I hope it's okay if I jump in. I don't know the answer to that question. It's a really good question. And it's actually something that I think a lot of people think about, actually, not just with psychiatry, but medicine. Like, do I keep being a primary care doctor and do palliative care? Do I be a hospitalist and do palliative care? I will say that almost everybody at this institution, which is like 15 and then 5 at the VA, 20 docs, are 100% palliative care. And maybe different parts, outpatient and inpatient and VA and Northwestern, but 100% palliative care. So we actually, not just in psychiatry, don't have good models for doing both. Now, I hope there are models. I will tell you, of the 3 people that we have trained over the years, as I was thinking about tonight, one went back to psychiatry. I think what he does in psychiatry is informed by palliative care. Another, Indrani, whose name I mentioned before, so I'll mention it again, is also full-time psychiatry, but does like 4 education sessions with us a year, does supervision of our fellows, does all sorts of amazing things in palliative care. So she is hybrid, although clinically, if you looked at her schedule, it's 100% psychiatry, which I think is, I know is informed by palliative care. And then Teresa's the opposite. She's a pediatrician and child psychiatrist who's 100% palliative care. So we don't have a great track record of hybridization. Doesn't mean it can't be done, but we aren't. I don't have good examples in my own experience of that. Molly and Carly, you may.
We've also trained 3 people in the time that I've been at Sinai, and one person went into full-time psychiatry, one person does full-time palliative care, and one does a mix of Geri Psych and Pal consults. But I will say, like, we've trained tons of fellows in specialties where they want to do part palliative medicine and part something else. And I think it's been really interesting to help those fellows with the job search process and find mentors. And in my experience, like, certain institutions are very friendly to that model and certain institutions make it really tricky. And it also depends on the departments that you're trying to mix. So having really good mentorship within the institutions that you're applying to, who can help you figure out how to navigate that, is really, really important. But I've seen lots of people succeed at that in all different specialties.
I would agree with it being very institution specific, which is probably marginally helpful for you all, but it might be something that's worth asking on your interview days. Like, at this institution, if I want to do more than one thing, is that a possibility with the information that you have at the moment? Because I would say institution dependent, department dependent, and just who's in charge of that department and how invested they are or not in making it work to have somebody appointed in both specialties or to kind of be a secondary appointment. And I think within our own division, that has been easier with some departments, like neurology, for example, than it is with others, for all kinds of reasons, including payment structures and who's in charge of those departments. So definitely something worth asking at each program, and perhaps something to think about when you're considering if you want to do more than one thing. There are exceptions to this for sure, but generally it's easier to combine outpatient psychiatry and outpatient palliative care, or inpatient psychiatry and inpatient palliative care, that it can be hard to mix settings logistically for your own lives and for that kind of dual appointment, and to have that be as smooth as possible. But I wish that there were a more universal answer to whether or not this was possible.
I agree there's a level of institution specificness. I also think palliative care is an evolving field and it's a young field, which makes it open to experimentation in a lot of ways. I have a dual appointment in psychiatry and palliative care. We have a neurologist in our division who's got a dual appointment in psychiatry and palliative care. We have a lot of people with like pain and palliative care.
Surgery.
Surgery. Dan Shaleva at Cornell has a dual appointment and is super cool because now he has an embedded psychiatric clinic in the palliative care clinic, which is such a cool model, but it's like the psych clinic of the pal care clinic, and he does consults for both. So it definitely can happen. I think a lot of times when people end up 100% one or the other, it's because they're just really called to one or the other. So I think what's beautiful about fellowship is you get a sense of what really calls to you and what you miss from general psychiatry, what you not miss. And there's a lot of leeway if you get to know systems well to figure out which ones will allow you to create the role that you want. But it certainly worked out nicely for me. And the other thing I'll quickly say, because Brendan added the comment, and we love wholesale too, but I truly consider palliative medicine my psychiatric subspecialty. So yes, I do have the dual appointment, but every day when I'm in palliative medicine, my outpatient palliative medicine clinic, I'm doing ACT therapy techniques with people. I'm managing depression. I'm managing anxiety. I'm holding space for existential distress. I feel like a psychiatrist. So even if you end up 100% in one, I don't feel like I gave that up in any way. Haley has a question. She says, thank you all so much for your time. It sounds like psychiatry is becoming more and more welcomed in HPM fellowship, which is so exciting. How do you feel primary team attendings and other consulting teams respond to palliative fellows whose primary training is in psychiatry?
It's ever been an issue. Like I can't think of a time when there's been a problem with that.
I can't think of a time when the primary team knew that the palliative care
I was thinking the same thing
necessarily.
Yeah.
Which is maybe in itself representative of them being indistinguishable from those who are trained in other specialties.
Yeah, no, I think it's, they are palliative care fellows, period. And, they are family medicine doctors and they are emergency medicine doctors. And when I say they, I mean we, and they are internists and they are psychiatrists, but they are palliative care fellows. So that's sort of what we lead with. Gosh, is it possible that someone might have some weird feelings? I suppose it's possible, and that's their issue, not the fellow's issue, quite frankly. But we have not seen anything like that at all.
Haley, I don't want to mind read here, but your question made me think immediately about what it was like to be the psych intern on a medicine rotation when I was in residency, and I was sort of labeled. I was like, oh, that's the psych intern doing her medicine rotation. And it was really pointed out. And then I would do well and somebody would be like, wow, you could have done internal medicine. And I'd be like, yeah, I know. And I chose psychiatry for a reason. I like it. But there was this constant awareness that I was the psych intern there. And I agree with our panelists from my own experience. It doesn't feel like that at all. You're just the hospice and palliative medicine fellow. To the point where I would sometimes have patients be like, oh, you're so easy to talk to. People tell me to see psychiatrists, and I could never see a psychiatrist like you. And I'd be like, gosh, should I tell them?
But when I was a fellow in my own institution now 10 years ago, two of my co-fellows were psychiatry trained. And I think it was the first time the program had ever had that, as far as I know. And they would sort of like buddy a psych person and someone else on weekend call. And we quickly figured out that was like totally unnecessary and we did not need to double dip in that way. And then one of my best friends in palliative medicine is Dr. Priya Krishnasamy, who's psych trained and was one of those people and went on to like win every award for best doctor in our department. And like, I would say if anything, like the psychiatrists really shine as palliative medicine doctors.
Yeah, if anything, that there's been the benefit of feeling a little bit like medically legitimized by the system once I switched over to palliative care, but that's, I don't know if that's a fair thing to call a benefit. That's more of a reflection of our very, even in medical culture, the stigma that people hold to mental health clinicians. Okay, another question for you all. one of the things that was very hard for me when I was in this training path is I had been taught certain ways of thinking about cases, of communicating, like a bunch of skills. And I came to this new path and I was taught all new ways. And I didn't it was hard for me to figure out how to merge the skill sets, how to develop a professional identity, how to sort of simultaneously be expert in one thing, but learner in another. So, what kinds of supervision, mentorship, other things someone can take on, do you think psych trainees and palliative care fellowships have found most helpful?
Hmm.
It's a little unfair for Carly because she can assign them to
I just refer everyone to Danny. I've like had to expend zero cognitive energy on this. I'm very spoiled.
The challenges with professional identity formation as you step into palliative care, I think, are like universal of all fellows. So I don't know that I would I'm not sure there's something different about psychiatry fellows in that. Like, I think everyone has their own individual struggle, but I think it's such a big change for so many people. So like even for the internal medicine and family medicine people, I think the way that we think through cases is really different than what residency training was like, and the way that we work in an interdisciplinary team is so different than medicine training. I imagine the psychiatrists are probably ahead of us in that piece of things. So I think just having really good mentorship from thoughtful people, ideally somebody that shares your training background, at least maybe external to your institution if you don't have a person like that. But I don't know that there's like a specific, I'm not sure there's a psychiatry specific challenge there.
I think your point is well taken. Like, there is value to finding a mentor who has integrated whatever are your things that you're trying to integrate. So
and can
if that person doesn't
community
exist,
and find you your people and help you get jobs and all that is really
yes,
for sure.
Find that person who can say, okay, this is how Vital Talk says to do it. This is how all your therapy training said to do it, and how do you make a
how do you merge these
that
things?
lets them both exist together? Find that person. Josh, any thoughts?
No, I think I was thinking as you guys were talking, I think that I'm thinking of different colleagues on our faculty, and I'm thinking of physicians, I'm thinking of advanced practice providers, I'm thinking of chaplains, I'm thinking of social workers. And I'm thinking all of them are integrating all sorts of things all the time, like the social work way to do things, and how can they teach us about that, and how can we kind of resonate with that. And we have a chaplain who is, a brilliant educator who does a whole spirituality rotation with our fellows, whether they are psychiatrists or internists, whoever they may be. So I think for any fellow, and I think any attending, like me, for example, I think we take different things from different people whom we work with. And, we have pretty formal, every fellow meets with me as the program director every couple of months, and every fellow meets with Gordon as the associate program director every couple of months, and we all have lunch every 2 months, and we have a meeting with Indrani for a sort of more psychiatric supervision that happens. And then each week you're on with Dr. X and Dr. Y and APPZ and social worker B, and you soak it up. Forgive the metaphor, but you sort of you take a lot from all those different people. So I agree. I don't think it's a psychiatry specific challenge. It's actually, I think, just a general challenge of development in this world. And I think the solution to it is to just be pretty deliberate and pretty curious. When I'm on with fill in the blank, we'll call him Jason. He's a doctor. When I'm on with Edward, who's a chaplain. When I'm on with Dana, when I'm seeing a patient, what am I getting from what they're learning, what they're doing, what they're role modeling? So while that may be, I was going to say, while that may be more true of psychiatry than something else, I don't know if it is more true of psychiatry. I think it's just for all of us, we have a range of mentors and experiences. Some are pretty formal, right? Like I was describing, but many aren't. Many are kind of who you happen to be with and who you happen to reflect with at the bedside.
Amazing. All right, those in the audience, keep your questions coming. But I can keep asking on behalf of you all. Maybe Molly, Carly, Josh, could you, if we zoomed out a tiny bit and just looked at the fellowship in general, for all comers, not just psychiatrists, for all comers, are there either things that seem most challenging or I guess certain fellows who have struggled more with like things you would advice you would give someone upstream who's not sure? They're like, maybe this is right for me, maybe this isn't. What's a predictor that this is going to be successful or not?
I've sort of said this already, but to go into it with as much, like talk to as many people in the field as you can and get a sense of what their life is like, and is that a life that is appealing to you. Talk to interdisciplinary team members, talk to the current fellows, and like get some exposure to the different models of like what jobs could look like after palliative medicine fellowship, and like does that seem like what you want to be doing with your life?
Yeah.
And I think the people that have struggled the most have been the people who really like had a big misconception about what it is that they were getting into, and the people that have sought exposure in different ways and really have a vision of what this looks like that's pretty accurate for the most part have been really happy.
Molly, I appreciate that. I think, this question of sort of what is life like as, where as is fill in the blank, is a really hard question for any of us, right? It's hard as a trainee, it's hard as an attending, it's hard as a child, quite frankly. So what is life like as is a really important question to be asking. And it's interesting. You can ask that of like a million different people. You can ask that of the Mollys of the world, or the Carlys of the world, or the Dannys of the world, or the Joshes of the world, or you can ask it of 10 other people. And this may be more about me than you want to know, but I cold email people all the time. Like, I read this really cool article. Hey, I want to talk to you. And, and part of it is like, well, what is your life like? And tell me a little bit about what you do. And for me, I'm pretty advanced in my career now, which I feel grateful for. So it's not like about choosing a career, but it may be even more important when you're choosing a career. In fact, I first met Indrani. I mentioned her before. She was a fellow with us 7 or 8 years ago. I first met Indrani because she did that with a former colleague of mine in Boston. She, again, sort of cold called her, and then she connected her with me, and ... So for the trainees on the line, I would not feel hesitant at all to get in touch with, someone you read about, someone you found online. And then, and this may sound controversial, if they don't answer you, email them again. And maybe stop at 2 or 3 maybe, but a lot of people just kind of, I think, take some interest in mentorship and in talking about where they got to. So I think, again, the task is understanding what life is like as, and whatever resources you can bring to bear in your own backyard, whether that backyard is New York or San Francisco or Chicago, but there are many other places. And even if you don't have someone in your own place that you want to do that to, you can, look and find someone somewhere else.
I would agree with emailing twice, because often people's inboxes are very full, and it's not personal or lack of interest. It's just that got to the bottom of the box. And I think generally that's interpreted as, like, those cold emails are interpreted as interest and due diligence, and those things are viewed as positive. I was also I was thinking about, like, when you're considering what is life like as, not just for psychiatrists, but kind of based on your frame of reference from residency and the things that you loved and hated, those are good questions for this as well. Like, when you talk to all those different people and get a different answer every time, there often are themes about what people like the most and what is the constant thorn in their side, and think about how either or both of those things will be for you. Like, are those things that are the best? Is that going to feel self-actualizing and interesting over what is hopefully a decades-long career? And are the things that emerge as themes that people could do without or really don't like, is that going to be tolerable for you over the same time period?
Mm-hmm.
I think one thing that's so interesting is that most fellowship choices narrow your level of options, but as a psychiatrist who did HPM, it felt like it opened it. Like, I could have a psychodynamic private practice working with people at end of life and existential issues. Like, I could go so many ways with what I learned. in that year, even if there weren't pieces that were or were not right for me. But do you all feel strongly about people, like, how do you feel when a fellow trains and let's say they do go back to their original specialty, but with like a palliative mindset or bringing those skills? Are you okay with that? Or do you have a strong stance for where you want your fellows to land on the other side of
Happy
this?
for them if that's what they want to do. It's so cool to bring these skills into psychiatry and into any other specialty. And I feel like they're gonna teach so many people and disseminate the skills so broadly that, like, delighted.
Broadens the reach. Yeah.
Yeah, no, I think it's wonderful. I'm not disappointed at all. And in fact, two close colleagues, and Johnny's one, and there's another one. Both kind of went back to, forgive the language, but to their native field. And I'm so proud of them, and they're doing amazing work. And again, I think that it's palliative informed, whatever that means. But I think if you were to ask them, because I had asked them, what was like that year important for you? They would say 100% it was important for me. Yeah. So yeah, no, that's not a disappointment at all. It's a great thing.
It's like a good form of inception. I think in our field we talk a lot about how there's a shortage of palliative care physicians, and that's true. But there's also a dire shortage of like mental health clinicians of all kinds, and so whoever, regardless of what people do, they're going to be doing good work that is needed either way. And I think if somebody did palliative care training and then are going back, especially to a psychiatry practice that has a training program, for example, or where they have others in their practice, there's kind of a downstream effect of that training that also feels like good work.
Yes, you should see me when I attend on the psych unit. Every one of those patients poops that weekend. Every pain has been assessed that weekend. Like, the nurses are like, yes, the palliative doc arrived. Kaylee in the chat has asked, in your experience, what qualities have distinguished the most successful HPM fellows, regardless of the specialty where they're coming
from? Being curious. Yeah. It sounds generic, but just always asking questions of yourself, asking questions of patients and families, asking questions of your colleagues, and then exploring those questions. It's not just asking questions, but exploring those questions and sort of getting to the next level. But just being constantly curious, and being curious both about your own sort of native stuff, as in psychiatry, but also curious about other things as well. I had a mentor a million years ago who was an he wasn't a mentor, he's a colleague, endocrinologist, and he used to say, you should go to medical grand rounds more often when you don't think you'll like the topic than when you do think you'll like the topic, because when you are sort of like, I don't really like that, then you're going to learn something. Whereas if the only medical grand rounds I went to were the ones that were about palliative care and communication and ethics and all those things, I mean, I'd probably be happy, but I wouldn't be pushed at all. So I take that to mean for any of us, take risks, be curious about things, and especially be curious about things that you aren't in your lane, if you will.
I was thinking about curiosity and also the general approach of having a growth mindset. I have not done other fellowships, in full disclosure, but my sense is that palliative care fellowship is more like an apprenticeship than other fields. And so you're going to have a lot of opportunities to be in family meetings with your attendings or interprofessional team members. And that's a really big part of it. And so the curiosity, and then really kind of being open to and genuinely asking for, not as a kind of exercise in demonstration of interest, really asking for feedback, and not necessarily, doesn't always have to be constructive, but asking, how might you have done this, and really being open to trying out that feedback. Everyone's communication styles are different, and you can decide, what of that you want to incorporate into your own practice. But so much of it is seeing different people's styles of medication management and communication and figuring out what you want to borrow and what didn't work for you. And so I'm really coming in being open to to that process of seeing how other people do it and asking them how you might do it differently or try it differently the next time.
It's a beautiful year of playing in the sandbox.
Yeah.
I would really echo what both Josh and Carly said, but especially what Carly said about growth mindset. I think one of my mentors is a guy named Bob Arnold, who always starts the fellowship year by sitting the fellows down and saying, like, palliative medicine is the only fellowship that people come into thinking they're already really good at it. Like, you probably came into it because you were a good communicator and you love family meetings and you love taking care of people with serious illness. And so I think sometimes fellows come into it with the mindset that they're like ready to go and get really frustrated by taking a step back and relearning communication skills and getting lots of feedback. But like, nobody would start a cardiology fellowship thinking that they knew how to do cardiology on day one of the fellowship. So really coming into it knowing that like it's a year-long fellowship because these skills are really hard and nuanced and like really important to learn at a high level, and being really open to that feedback.
And I think the beauty of all of your points about curiosity is that suffering is a huge, complex thing. It has so many dimensions: the psychological, the existential, the physical, the relational. Like, there's just so many dimensions. So none of us are experts. I feel like I could be in palliative care and I could be learning more about suffering from now until the day I turn 90, if I'm lucky to live that long. So I do think an excitement to feel like you're never totally expert. There's always something more you can learn about the nuance of suffering. Probably helps people feel good in this field. Brandon has a question which kind of overlays with one of my questions. So Brandon says, there are certain burgeoning fields of research, including psychedelic-assisted therapies, that appear to share a fair amount of overlap between use cases in psychiatry and palliative care. I imagine it may depend on institution, but do you all think that is an area of research where pal care fellows from psychiatry backgrounds may be able to get involved? And other than psychedelics, do you think that there are other interesting areas of research overlap as well? I'm going to add to Brandon's question because a lot of psychiatrists who come to this ask me stuff about, like, what about the void of care, the inequity of care, of palliative care for people who have serious mental illness or impaired decision-making capacity? What about this idea, can a psychiatric illness be like treated palliatively? So there's a lot of these spaces. Is this something that you can envision palliative care fellows from psychiatry being able to get involved in? Or
the short answer is yes. And Danny, your comment is an apt one. At our 12:30 conference today, Indrani and a psychologist here at Northwestern did a topic about palliative care and psychiatry and serious eating disorders, which Indrani has been part of a group at HPM that did that a couple of years ago. So serious mental illness and palliative care, all sorts of stuff around grief and bereavement, where I think we have a lot to learn. At least I have a lot to learn. So I'd like to think my psychiatry colleagues can be good teachers and researchers in that area. I think the topic of suffering that you mentioned obviously has intense psychiatric, psychological, existential components that needs the perspectives of everyone, period, and whoever you might be, but maybe psychiatry. And then I think just in general, I mentioned this the sort of attachment theory, and I was sort of being a little bit of a devil's advocate as I was saying that, but this kind of more developmental perspective that I think a lot of psychiatrists have taught me about. I'm a hospital-based palliative care consultant with an internal medicine background, so it's very like there. The immediate is there, but of course it's not immediate at all, because what this patient is going through is reflecting what happened to them yesterday and last week and last year and 10 years ago and 70 years ago. And so that kind of, again, I'll call it a developmental perspective, which is, I think, not quite the right word, but that kind of perspective is, I think, an area that's also really ripe for research. So those are just some overlap syndromes, if you will, that I can think of.
I think one thing that I love about this field, I am not primarily a researcher, but there is so much that we don't know, like really basic things like what antidepressants should we use when people are really depressed and have a limited life expectancy, like all kinds of things. We're not on Timmy 87. We're not talking about like aspirin 81 or 82. There is a ton of stuff, far more that we don't know than what we do. And so I probably don't even have enough awareness of kind of the aspects of psychiatry that could be added into the field from a research standpoint. But in all fields, there's a lot that we don't know and a lot that can be added by research.
I will shameless plug my own institution. My wireless is in and out, but we have a new 2-year palliative leadership fellowship that we would totally welcome psychiatrists applying to. And one of our fellows who we're super proud of and kept on last year as faculty is a family medicine trained person who did his 2nd year thinking about psychedelics at end of life, which we don't do at my institution, but he sought out a research mentor at another institution and was able to do a big project, went to a bunch of courses around the country to learn more about that. So I think there are, like, people are doing really cool stuff, and you can find projects outside of your own institution if that's not something that your place will let you do.
Yeah, I wholeheartedly agree that it's sort of like more than most fields ripe for the picking. We need so much more research in this space. So Dan Shalev is, I mentioned his integrated clinic, but we have 1 million studies on integrated clinics in palliative care. He's doing the first ones on integrative clinics within, like, integrated psychiatry, embedded clinics within palliative care clinics. Or we have 1 million in primary care. I think I said that wrong. But similarly, the rates of depression, anxiety, trauma getting exacerbated, really like PTSD, medical trauma, the rates of psychiatric illness in the patient population that is palliative care patients are so much higher than the general public. And yet the vast majority of the evidence we go off of when we make our decisions is from general population studies that almost always have actually excluded our patient population, excluded these patients with serious medical illness, like, from the studies. So it's very interesting to me every time new studies come out in our population, we learn a way that they're different than these general population studies, right? Like, your general population will gain weight on mirtazapine. Guess what? Your palliative care advanced cancer patients won't. And that's unfortunate because we've been promising it to them as a weight gain miracle. So I think there's so much psychiatry research to be done in the palliative care space that it would be very much like an all-you-can-eat buffet. Yeah. All right. We are almost at time. Somebody put something here. I'll throw it out there and you can lightning round answer it. Do you feel like HPM fellowships at large are becoming more receptive to training psychiatrists, or do you think that this panel represents programs that are particularly invested in this? How likely do you think a psychiatrist is to be immediately declined, similar to my experience?
We're fighting for the psychiatrist. There's like a secret network of program directors and we all talk to each other. And I know this year, at least the New York City people were all fighting for a couple people, and it was very fun to watch that play out. I think there's a lot of enthusiasm.
I will agree with this sentiment. A program that I now know, the new fellowship director, that explicitly would not, 1 million people called, they just wouldn't even talk to me, is now calling me up and she's like, I really want a psychiatrist, like, help me get a psychiatrist over here. So I think both, and this is, we did pick these people on this panel because they have trained psychiatrists and are very open and invested to this. And I think that there is a larger shift in the field, as evidenced by like the content at our national conferences and like how much excitement around the psychiatry palliative care interface has been brewing.
That's my sense too, Danny. And that's due to people like you and Carrie and Dan and others, obviously. But many in this field have just been kind of pushing this. There's this like huge, someone I think used the word burgeoning. I think that's totally true. The other point, I hope this doesn't sound too kind of blunt, but if there's a program that doesn't want you, you don't want them, period.
Yeah.
I mean, it's just not a good sign on their part. So I don't think that'll be too common, but quite frankly, if it is, just like with any kind of thing that you're evaluating, you should take that as a piece of data. And like I said, I hope that won't be a common thing. And I just think it's a field that is so welcoming for psychiatry in so many ways.
Well, on that optimistic note, I am a psychiatrist and I will hold frame. We only have 1 minute left. I will thank you guys
I've noticed
so
our
much.
time is over.
Thank you so much for your time, for coming, for sharing your wisdom, for the ways you are training so many people in this beautiful, beautiful field of ours. So we really appreciate you.
Awesome. Thanks so much, Danny. Thanks, Gail.
Thanks for having us and hosting.
Appreciate it.
Thank you.
Bye, everyone.
Bye, everyone.